At the outset, I would like to thank Dr. Jaspreet and Dr. Chintan, that is the President and Secretary of Chandigarh Ophthalmological Society, uh, those who have given this opportunity, and especially Dr. Diksha for the whole conceptualization of this. I told her that I'm not going to speak. She said, no, you have to speak. And I'm so happy today that most of the speakers here, I think they've been associated with me at one or other time. And it gives me a lot of satisfaction that what kind of great work is being done by all of you, as far as the ROP is concerned. I'm just going to touch upon a few things about the surgery. I'll not go into many details because this is a subject which is a little different and very few people are doing surgery. Uh, I think if we look at the current treatment of ROP, of course, we have not included a pediatrician or a neonatologist here. It is the close monitoring of oxygen saturation level, as well as that is one big problem we always discuss, why we have higher birth weight babies problems and certain related issues. And of course, what has been very nicely covered is the peripheral retinal ablation with laser is the gold standard. And we have seen numerous example and excellent demonstration by Anand showing us so many such cases, and subsequently some of the cases shown by Gaurav. And anti-VEGFs, I think we had very good talks, both talks by Simar as well as by Gaurav. And they have a role, they are there to stay, and they are getting now foothold more and more, even now DCGI approving ranibizumab for ROP. I think what I'm going to a little bit touch here is a vitreoretinal surgery in stage 4 and 5. And of course, this has been very well dealt, that timely screening and laser. It is a timely screening, which we talked earlier, and laser, which improves the outcome. And I think as far as the ROP surgery is concerned, and vascularity is a significant factor that may sometimes preclude surgery. I think this is a recent publication from Parijat Chandra and his group. They have done this combined kind of a approach where they have given in such eyes preoperatively, and they have shown very good result. I think this is something you can look at, and that is, and of course, other things which has been dealt very nicely. I'm not talking about them. So what are the current surgical approaches as far as the ROP is concerned? Sterile buckling, which was one of the mainstay long time back, and it was being done very often, is rarely performed these days because it is lens sparing vitrectomy, which has been done more and more, even in these kind of cases where buckle was needed earlier. And of course, lensectomy and vitrectomy, especially for advanced stage, is very much there and is being performed in many centers. So I think what is important for us to know is that ROP surgery is a different from adult retinal surgery. And I think that is something which we must understand thoroughly. And there is always a discrepancy in the anatomic and the functional outcome. That means we have to be very careful when we explain the risk-benefit ratio to the parents and obtain informed consent. You have to repeatedly kind of go back to them and take a written consent, because there could be a problem. Their expectations are very high. You know, this child which is born premature, one has been saved after so many, first thing is we never talk about this. I used to talk some of with you, but why the child is born premature? They have high risk pregnancies. They lose so many children. They get this one after difficulty, then who has a major issue. And of course, experienced anesthesiologist is required, and that is something which is very important if you want to start this surgery. I think indications are important from point of view of even whom to refer. If you have a case of stage 4A, 4B, or stage 5, they may need surgery. And many of them, they may need surgery, but depends. Then the most important is you already performed a laser and there is a progression despite laser treatment. That means progression especially could be of two kinds. One is that you just have the disease where there's a hemorrhage, you may give injection and other things. Despite that, you have a lot of proliferation happening and the disease is progressing. So don't wait on such a case. Send such a case very early. Then sometimes there's a dense vitreous hemorrhage. You can't even see. I think these cases need, and all bilateral cases. If both eyes are progressing or you have a both eye problem, then it is even a emergency situation. If one eye is good and other eye has a problem, it might be okay that you want to dilly-dally, or if the patient has a problem, maybe you might be sort of looking at such a situation a little more comfortably. I think already Gaurav has covered this, but I wanted to put up the first thing, which in fact in this publication we have everybody whosoever had pre-existing or new onset fibrovascular proliferation after laser treatment. If you go to all of them, they went on to unfavorable outcome or progressed. This way, in fact, he didn't even put when he was analyzing into that, because they were all already there, those who were progressing. And of course, he talked about the posterior zone 1 and other factors. So like this is a lasered baby and lasered eye, and how it can progress. And so it can progress, and if you let it progress, that is where you want to go earlier here, and not when it has already gone on to stage 4B. Look at this, how it has progressed very fast within 2 weeks. And you have this kind of a progression and a very aggressive disease presented late, very well lasered. And if you have these situations, you have to act very, very fast and take up these for surgeries. And lens sparing small gauge vitrectomy is something which is most important at this time for 4A, 4B. And early LSV is required if you have a progression despite your laser or injection, and it will give the best result if you go and do early. I think reattachment is seen usually in 60 to 85% of eyes. There are now even series available where in 4A you might have all eyes. We have shown they can give almost 100% results. I think here we have a lot of these studies from our country, but I would mention this last one by Praveen Sen et al. All these from Sankar Nitralaya, they are doing a lot of surgeries. I think this is a very good article. I think I'll not go into this. It's not important. I think nicely covered by Simar that where we need to go. That's the same thing here. Maybe 1.25 you go, and that's where you want to put a sclerotomy at a place where there is no fibrovascular proliferation. And the trocar and other surgical, they have to be angled again towards the center of the eye, which he mentioned. And of course, I'll not even mention this, that how you and what you need to perform. I think that is, and we have a problem here with the hyaloid. And at the same time, sometimes limited hyaloid can be removed posteriorly. You can use sometimes small amount of triamcinolone for that. I think this has been described very well, I think by Parag Shah and group. And you may have a situation like this, follow up at post 1 week, right? Look at right eye. Right eye, there is a limited amount of fibrovascular proliferation. Somebody had done in olden time study where it was said that if you have more than 4 clock hours of fibrovascular proliferation, don't wait, do vitreous surgery. I think it is so true, it appears here. Look at the other eye. It has so much of proliferation almost going all around. And within 2 weeks, you can see the right eye is absolutely fine because there was hardly any proliferation, and left eye, the whole retina is contracted onto the disc. And of course, LSV was done. I think this Diksha had done excellent job, and you can see how well the retina has gone back. And this is another one which we had done when I was there. And you can see the same one. You can see how fast it's progressed. And of course, you can still give here good result if you do a timely lens sparing vitrectomy. I think some new innovation in lens sparing vitrectomy. I'm here interested in the nasal LSV, and we are very happy that this all nasal approach where Simon has done a wonderful job by creating so many kind of contributing to it, where this is accepted in retina and has appeared head of print in the May issue. And I think this is ideal for stage 4B with extensive temporal. I'll not show you much of the video here, but what is important here is, if you see, what is important is that if you go from the nasal side and you can see here, if you go on the nasal side, this cannula itself rests there. I'll just show you how you approach, not the full surgery, because this is a 13 weeks old infant, and the surgeon is sitting on the nasal side, and this was performed when I was still in PGI. And you can see, once you put it at 1 or 1.25 millimeter, we never realized that this is the best approach. This itself, this nasal bridge here, this doesn't allow it to touch the lens, which used to be a problem always when we made it temporally. And you make these on two sides, these two ports. That is what it is. And you can very easily approach most of the parts which you want to surgically tackle by going through this. You can see how bad the case is for B here, isn't it? So I'm not going into the detail of the whole surgery, but this case did very well. This is after 6 months, the same eye, well attached retina, and that is what is can be achieved. I think lensectomy and vitrectomy is for stage 5. Stage 5 is a challenge. We have to do surgery in these cases. Some of them have a better reattachment rates, but overall reattachment rate is still 1/3. Again, there is this from Praveen Sen et al. From Shakanitralia online. This is an April issue online versus a May issue, where they have done the surgery in stage 5 and shown 33% reattachment rate. I think but the problem is the functional results are very poor. So that's what is the problem. So in conclusion, as far as the surgery is concerned, lens sparing small gauge vitrectomy is the most important in ROP surgery for 4A, 4B. I think this should be done more and more by more centers. And early lens sparing vitrectomy in progressive 4A, whether it is because of after laser or it is after your injection on combined, is preferred at this time. And lensectomy and vitrectomy is required for the stage 5 and is usually results in a poor visual outcome. But I think more of a better cases should be done, because sometimes they may get ambulatory vision or the count too close, count finger close to face kind of a vision or hand movements, which is very good for them. So thank you very much.